Neurology Quiz number 80. Discuss the etiology, clinical features, and management of Rasmussen's encephalitis. Rasmussen's encephalitis, also known as Rasmussen syndrome, is a rare and chronic neurological disorder characterized by unilateral inflammation of the cerebral cortex, drug-resistant epilepsy, and progressive cognitive and neurological deterioration. Clinical features: the disorder is rare and most commonly affects children and young adults. Studies in the United Kingdom and Germany have revealed incidence between 1 to 7 per 10 million people aged 18 years or younger. The median age of onset is 6 years, but cases have been reported from infancy to childhood. In the acute stage, the presenting feature is frequent seizures arising from one cerebral hemisphere. About 50% of cases have epilepsia partialis continua. With progression, other types of focal seizures are seen, indicating involvement of different areas of the brain. Affected children develop hemiparesis, hemianopsia, language disturbances with dominant hemisphere involvement, as well as cognitive decline. Eventually, there is a relatively stable residual stage with severe and fixed neurological deficit, motor and cognitive disability, and persisting difficult to treat or drug-resistant epilepsy. Less common features include a prodromal period of mild hemiparesis or infrequent seizures that precede the acute stage by a few years. 10% of cases start in adolescent or adult life. The clinical course is slower and residual deficits are not as severe as in children. Semiology may be more characteristic of temporal lobe epilepsy. Presentation has been described with unilateral movement disorders such as hemiatrophy and hemidystonia. Investigations: MRI, brain imaging is vital for diagnosis and follow-up. Within months of onset of the disease, most patients show unilateral enlargement of the ventricular system. T2 and flare hyperintensity is noted in the cortical and or subcortical regions. The perisylvian region is particularly affected by volume loss and signal change. Ipsilateral atrophy of the head of the caudate nucleus is also a common finding. Serial MRIs typically show progression of signal change and atrophy. FDG PET can show diffuse hypometabolism over the affected hemisphere when MRI atrophy is minimal. These images from a 5-year-old patient with Rasmussen's encephalitis show left hemisphere atrophy in T1, T2, and flare images in axial and coronal views. These T2 and flare images from a similar patient show diffuse left-sided hemiatrophy with encephalomalacia and gliotic changes. This picture shows a PET scan which demonstrates diffuse hypometabolism of the right cerebral hemisphere corresponding to atrophy on the MRI in a patient with Rasmussen's encephalitis. EEG: there is no specific finding that distinguishes Rasmussen's encephalitis from other causes of focal epilepsy. Persistent high amplitude delta activity can develop over the affected hemisphere within months of seizure onset. Epileptiform abnormalities are commonly seen and can develop into electrographic seizures, but EPC is not always associated with ictal surface EEG activity. Independent ictal abnormalities can also develop in the non-affected hemisphere. However, these do not indicate bilateral disease, but they can be a marker of cognitive decline. This is a picture of an ictal EEG in a patient with Rasmussen's encephalitis and EPC of the right leg. These are diagnostic criteria for the disease proposed in 2005 by the European Consensus Panel. Part A includes clinical EEG and MRI criteria, while Part B includes clinical MRI and pathology criteria. Pathology: characteristic features include cortical inflammation, neuronal loss, and gliosis in one cerebral hemisphere. Microglial and lymphocytic nodules, neuronal death, and neuronophagia are common. Eventually, there is prominent astrogliosis and cortical cavitation. These features are consistent with an immune-mediated disease. Antibodies to antigens such as glutamate were initially reported in some cases. However, this was only found in a few patients and plasma exchange was not noted to be effective. The role of CNS autoantibodies remains unclear. T-cell cytotoxicity seems to play a major part in the pathogenesis of the disease. These slides show the characteristic neuropathological changes in the disease with perivascular lymphocytic cuffing, microglial nodule formation, and a neuron undergoing neuronophagia. Medical treatment, anti-seizure medications. These do not affect the progression of the disease and have only a limited effect on the seizures. EPC is often refractory to anti-seizure medications. A more realistic goal of using anti-seizure medications is to protect the patient from severe seizures, such as bilateral convulsive seizures. Treatment is adjusted to achieve optimum seizure control with fewest side effects. There are case reports of injection of botulinum toxin into the facial muscles for facial myoclonus and into the upper extremity for localized EPC to reduce painful spasm and improve limb functionality. Other case reports have indicated seizure improvement with use of VNS. However, in most cases, seizures are resistant to anti-seizure medications. Immunosuppressive and immunomodulatory treatment. The effects of long-term immunotherapy have been described either in case reports or in small uncontrolled patient studies. The most positive experience has been noted with long-term corticosteroids, IVIG and plasma exchange, and T-cell inactivating drugs such as tacrolimus and azathioprine. A treatment regimen consisting of initial treatment with steroids and then switching to tacrolimus has been used. The influence of such treatments on the long-term outcome of patients is still unclear. Surgical treatment remains the only curative treatment for seizures in Rasmussen's encephalitis. This consists of hemispherectomy or hemispherotomy. Sequelae include hemiplegia and hemianopsia, as well as language disturbances with disease of the dominant hemisphere. Smaller resections can be done to preserve function but do not provide the same degree of freedom from seizures as conventional hemispherectomy. Hemispherectomy is associated with more than 70 to 80% long-term seizure-free outcome. Timing of surgery is guided by severity of epilepsy, appearance of EEG abnormalities in the contralateral hemisphere, which is a marker for cognitive decline, can be another indication for surgery. This is an algorithm for suggested therapeutic management of the patient with Rasmussen's encephalitis.